All right. Good afternoon, everybody. My name is Jessica Cecil. I'm the Education Coordinator at the National Aging Research Institute. Welcome to our online Seminars in Aging program. I'd like to begin by acknowledging the traditional owners of the land on which each of us are meeting today. For me, that's the Bunurong people, and pay my respects to their elders, past, present, and emerging. Firstly, a little bit of housekeeping regarding Zoom. At the conclusion of the talk, we'll have some time for Q&A. If you have any questions, you could submit them throughout the seminar using the chat function, which can be opened using the chat tab at the bottom of the screen. So today we're going to be hearing from Anna Peters. Anna is Director of the Institute for Health Transformation and Professor of Epidemiology and Equality in Public Health at Deakin University. She is Principal Research Translation Investigator at Western Alliance, an NHMRC Investigator Grant Fellow, Board Member for the Victorian Health Promotion Foundation and Obesity Australia, Chair of the Deeble Institute for Health Policy Research Advisory Board. So she is internationally recognised for her work building the evidence for effective and equitable policy and practice to improve health outcomes. And today she's going to be presenting Delivering Enhanced Healthcare at Home through Optimising Virtual Tools for Older People in Rural and Regional Australia, also known as the Deliver Project. So welcome, Anna, and over to you.
Thanks very much, Jessica, and thanks to Nari for the invitation to speak today. It's a real pleasure to present this newly awarded grant to you at its very early stages. So hopefully opportunity for lots of useful feedback to help us inform this project. So I wanted to start with an acknowledgement of the lands that we are all meeting and working on, and pay my respects to the traditional owners of these lands, and particularly pay my respects to Aboriginal and Torres Strait Islander elders, past, present and emerging, and any Aboriginal and Torres Strait Islanders who might be present today. I just wanted to give you a really brief introduction to the Institute for Health Transformation first. For those of you who are not aware of it, we do have lots of collaboration with NARI, so I'm sure a lot of you are, but I just wanted to briefly set the scene. So the Institute for Health Transformation is a research institute at Deakin University, and really the underpinning core values and goals of the Institute are this belief that health shouldn't be hard. So our purpose is really to drive collaborative research with partners such as NARI and health services and NGOs and communities to transform the design and delivery of prevention and care. And so we have a really broad spectrum, as this says, from prevention through to healthcare and care of disability and aged care services. And by bringing those things together, we really aim to address some of the more complex health challenges with that purpose, as I said, of making better and health and wellbeing easier for everyone to achieve. So quite a strong focus on equity. Our research really brings together a lot of different perspectives. So we have more than 200 multidisciplinary researchers currently across 5 broad research areas, really aiming to address the drivers of the health system that make it hard for people to be healthy. So that's where the sort of design and delivery comes in. So our broad research programs are obesity prevention, health economics, quality and patient safety, determinants of health, and behavioural research in diabetes. And the Deliver grant is a really good example, I think, of, so we formed about 3 years ago, the Institute, and the Deliver grant's a really good example of bringing together all these different perspectives and disciplines and partners to try and have a really substantial impact on health outcomes. So the Deliver grant is a big program of research that I lead through Western Alliance, which is an academic health science centre in Western Victoria, so rural and regional. And it stands for, as Jessica read out, delivering enhanced healthcare at home through optimising virtual tools for older people in rural and regional Australia. So yeah, never let a good acronym get in the way of a slightly wordy title. So to give you a little bit of background to this grant, essentially the goal is twofold. So one is really focused on what do we need to do to build rapid research translation capacity. So that's kind of one of the big planks of this grant is working across the region to think about how to build that in a sustainable and effective way. and then to use that research translation capacity for digital optimisation of health service provision of home-based care for rural and regional health systems. And we've had lots of good conversations, and I'm sure some will come up about what about other providers of this sort of home-based care. So it's certainly not that we don't think those things are critical and important, and it's not that we're not going to try and integrate at least the learnings and the capabilities, but this program of work had to have a level of containment. So this focus is really around health service provision. So the rationale, also just in terms of context, so this was a really good scheme for those of you who are, if it comes again, who have the opportunity to apply. So the Medical Research Futures Fund last year had a rapid applied research translation funding scheme with a rural stream. So it was perfectly aligned to what we're trying to build in terms of capability and research translation. And so we were able to get substantial funding over a 5-year period, which, obviously means we can try and do something really good. So the rationale for this particular grant was really focused on sort of the inequities in health outcomes experienced by particularly older Australians living in rural communities. And we know that those higher rates of poorer health outcomes are associated with many things, including things like poor access to healthcare services. We also know that the needs of older people can be more complex. And so not only is there a higher need for care, there can be a reduced capacity to access care. And as you know better than me, this can really be compounded in rural settings. And so we kind of posited in this project that improving the care of older Australians in rural areas remains a significant unmet need. One of the opportunities to think about addressing this need is home-based care, so it has the potential to address some of it. However, some of the gaps at the moment are that existing home-based care efforts can often be disconnected and ad hoc and quite heavily dependent on the face-to-face experience, which is not always practical in rural areas. And that a number of the care integration solutions that have been demonstrated to work in metropolitan regions may have limited transferability to rural settings. It's also the case they may not, but I guess the point is that they haven't been tested, and so that is one of the goals of this grant. So obviously technology is one solution to improve connectivity of care and capacity to deliver home-based care for older patients in rural areas. And so one of the premises of this grant was that, while virtual care is clearly not new in Australia, it can be much more effectively used to support patient-centred integrated healthcare delivery, and in this case, particularly for older people in rural areas. So the aims of this project, and sorry again that they are a bit wordy, but these are the precise aims, so it's probably worth you knowing them, I think, to the extent that we can then think about, pointy questions after the talk. So one aim is really, as I said, around the optimisation of home-based care. So I will read these out. Perform rapid identification, prioritisation and testing of local solutions to healthcare at home that address these key challenges of delivering healthcare at home to older people in rural areas as identified by our health service partners, which includes obviously partnership with community and consumers. Second one is, as I was saying before, really that platform of how do you actually build a research capability or a research translation capability to enable this sort of research in an ongoing way. So it's not just a one-off project with a one-off outcome. So the second aim is to build and evaluate a sustainable model for rapid rural clinical and health service research and translation across Western Victoria. And then one of the key outcomes that we're aiming for is by performing kind of aims 1 and 2, to try and identify some optimisation or some amendments to healthcare at home programs in terms of making them better meet the needs of older people living in rural Western Victoria, and then to try and implement and evaluate, and if it's effective, scale this program, this optimised program region-wide. So in terms of how we're going to be approaching this, it's clearly a huge partnership project. So we have a number of different universities from across the state. We have a number of different health services, and they're not all listed here, across southwest Victoria. We also obviously have government and primary health network input into this program. And then we've got 3 national peak bodies really to support us in particular areas. So NARI obviously is one of them, and Sue Williams, who I don't know if she's on the call or not, but has been a fantastic contributor already in terms of just how we think about the unmet needs of older people and expressing things in ways that are perhaps more cognizant of what the older person experiences today. We've also working with the Australian Healthcare and Hospitals Association, quite interested to use their reach across the country and their knowledge in terms of policy implementation to look at how any of the outcomes that we identify might be disseminated and scaled across the nation, and the Consumers Health Forum of Australia to support us in trying to really make sure that the consumer engagement is embedded throughout and done in a very meaningful way. The principles that the program of work are founded on, initially at least, and these may iterate over time. So we really are focused on how do we drive and develop scientific capacity that is locally situated, so that it really can develop scientific or evidence-based solutions, if you like, that are relevant to those communities and health services. Collaboration, as you've seen, is pretty much at the core of this whole program. It's one where we haven't sort of set out to say we're going to do A and then B. And that is a definite challenge of this large program of work, but I think the advantage of that is we're setting it up so that it's sort of a continually learning process, and the aim is that we really want lasting impact, so we're continually reviewing each of our steps with those principles in mind. Similarly, we've started to think about some of the design features of the broader program to make sure those principles and our aims are met. And so the evidence informed part is obviously really founded on data, and this is all forms of data, not just numeric data, strongly founded on co-design with consumers, with health services, and then with the broader stakeholder groups. As I've said, in terms of learning, we're really trying to build both the capacity building and the home-based care optimisation projects to be adaptive, so that we can continue to build on what we've learned. And as I said, it's not just one fixed outcome. We want the outcomes to be scalable, and so throughout, we're sort of embedding processes for our large project team to reflect and evaluate. So one way of thinking about the process that we are going through is really looking at how do we embed research capacity and a kind of learning health systems approach. So I've got a few slides on this, and I won't go through all of them in detail, just in the interests of time. So we've got lots of time for discussion. But if there are questions, I'll absolutely ask them. So the kind of approach here is that we're basically working with the different rural and regional health services and the other partners that I put up before, and consumer groups, to start to identify what are the local solutions to home-based care that are likely to be useful to test. So what is it in the current delivery of home-based care, if you like, or in delivery from elsewhere, so such as I was saying about metropolitan, or learning from other areas in the country? What are some of the elements that our health service and consumer partners think might be applicable in this context to improve outcomes of older people in this rural setting, related to home-based care? And so through the co-design and the priority setting processes that we're putting in place, we'll identify those potential solutions, and then we work with our different evidence arms. So it might be doing systematic reviews, it might be a health economics question, it might be a digital question. We'll use the different research capabilities we have to test some of those solutions locally, and so that we can then get feedback from those health services and those consumers about, yes, that's a solution that looks like it might be good, or no, actually it was not good after all, so we need to try another one. And so that iterative process is what we're trying to establish, so that we can do that in different settings across Southwest Victoria, and start to build up a bit of a bank of, well, these are solutions that might be useful for delivering home-based care in this region to older people. And so once we sort of have that bank, we can start to think about, is there a region-wide home-based care program that we might be able to implement across the region? and evaluate it with an eye to further scalability and embedding. All of this, as I've said, is really centered on the idea of building the capability to support all of that research evidence development through rapid applied research translation. So just to give you an example, I know it can be a bit kind of theoretical. So just to give you an example, so I won't talk through both of these, but it gives you two different examples. So illustration one might be, which has come through clearly already, quite a simple, conceptually simple issue. So the challenge that has come through from health services and patients has been a lack of internet connectivity, you know, working through what's available in the literature, what is it that people have tried and tested before, what is it that consumers and the health service or healthcare professionals think might work. You know, one of the potential outcomes is provision of an iPad with a dongle so that you're not dependent on, you know, your local connectivity. And then the idea would be, okay, well, what do we need to help build to identify whether this is a good intervention to test? And there are things like rapid reviews of evidence from around the world. We do SimLab testing with patients to see if it is a good solution from the patient perspective, and then a cost analysis to work out whether it's a feasible solution for the health services across the region. And if all those things come out as, yes, this is something worth testing, then we do a small implementation trial in a health service to get feasibility and outcome measurements. So in terms of the capability building, I did just want to spend a minute on the approach that Western Alliance already has in place. So they've done a lot of work trying to work out what does a really good capability building model look like that can work for health professionals across, in this case, Southwest Victoria, and particularly rural and regional Victoria. And so they've done a scoping exercise. They've done both in terms of the literature and in terms of working with the healthcare workers across the region. What are their training needs? What are some of the capability gaps, both at an individual level, but also at an organisational and regional level? And so again, I won't go through this in detail, but happy to share the slides. So they have developed, previous to this grant, a really comprehensive research, training and capability building approach, which they call the STAR approach, which has a number of guiding principles, as you can see there. And the important thing to note is that they really pick up the organisational capabilities, the health manager capabilities, and the individual capabilities, and then some of the areas that we know are important in addition to perhaps more traditional training, such as mentoring and organisational support. And so the Deliver grant was written specifically to build on what capability is already there, so to build on the STAR program, with the idea being, how do we start to add in more capability? So training in things like implementation science and health economics, and system science. How do we add those things in that we know are really important for research translation, and as well as boosting the capability of health professionals across the region to participate in the training modules that already exist. So just to step you through kind of what this might look like a little bit, and as I said, we're at the early stages, so all ideas welcome. You know, there's a large focus on trying to get our engagement and co-design principles and processes right before we go too far. And so we're really looking to bring together representatives from health services, from the PHN, consumer and carer groups and community organisations to start to think through, as I said before, what are the areas that it would be most beneficial for us to invest our time in. And so the sorts of questions that we're asking or we will be asking of these groups are really around across the whole spectrum of what we're doing in the grant. So we want input in terms of identifying the challenges to home-based care. We want input to co-designing solutions. We want input in terms of thinking about how they might need to adapt to different community or healthcare settings. We'll need input in terms of what implementation strategies look like, what does evaluation look like, and what does the capability building look like that we need to support the endeavour that we're trying to build. So then, as I've said, that will inform those other steps, which is around identifying and testing potential local solutions to home-based care. And the sorts of activities that we're going to be using here, and these are kind of more around methods. So I will step through it, but happy to talk more about it later if any of these particularly interest you. The sorts of methods that we're bringing together, and that's kind of one of the big excitements to me about such a large partnership, is, you know, we have experts in sort of consensus mapping and systems mapping, in terms of optimizing and feasibility testing, in terms of rapid evidence synthesis, such as, you know, systematic reviews and rapid reviews, in terms of data integration, sim lab testing, health economics, such as health costing and financing, and a lot of expertise in implementation science and translation. So these are the kind of disciplines or perspectives that we're wanting to bring to bear to these phases. And as I said before, all of this is continually supported by kind of ongoing capability building. So just as, again, to sort of try and make it a bit more tangible, even though we're at this early stage, in the first year, the sort of thing that we're going to be inviting health services and the community to engage with is, you know, informing that choice of which of the home-based care programs that are currently running might we be able to support improvement of. Do we need to look at completely new ones? But our preference at the moment is really to support the health services and the communities to improve those programs that they already have in existence. We really want them to start to give us their expert thoughts on, you know, which of those solutions that we might come up with as a broad group would they prioritise, and we've got some priority setting matrices that we use for that. What's actually able to be tested in their local context and how we might best do that, and then to let us know what research capacity they already have and what they might need to be able to really actively engage in this program. And again, just to add that bit of kind of specific context, so one example that the health services have identified as potentially a good focus, which I would imagine, you know, a number of you might have some thoughts on, is the geriatric evaluation and management program that a number of them run in slightly different ways. And so they're kind of interested in looking particularly at, are there ways of monitoring indicators that of early decline or early indicators of need for more intensive support? Are there ways that can be done that is more accurate, more timely, more acceptable to the patients, and potentially also more efficient? So they're the kind of things, as you can imagine, that we can draw a lot from the literature. We can also then engage with our digital health specialists to think about perhaps opportunities that haven't already been used, and a health economist to think about how might this actually be delivered and funded. So I did want to touch a little bit, I wasn't 100% sure on, you know, what your areas of interest might be. So I did want to touch a little bit on governance and working group structure, mainly because, as I said, we've got Sue Williams engaged, which is fantastic. But this could be a little bit dry, so apologies if it is, but I really wanted to put it out there just because you might also have some thoughts of others who would be good to engage with, or other perspectives that perhaps are missing at the moment. So the governance framework we're working with at the moment, because it is such a large program of work that does require so much integration. So we have a governance committee and an external advisory committee, and I'll talk through those in a moment. And then we have the project executive, which is really responsible for the delivery of the project over the 5 years. And then we have a number of working groups to try and make sure that, you know, some of the important things we have to do don't fall between the cracks. So some of them, such as the local solutions working group and the program evaluation working group, as you can imagine, are a bit more technical. The capacity building working group probably speaks for itself. And then what we're trialing with this, and it may evolve over time, is to have one working group that really cuts across the whole project and interacts with all the different working groups to make sure that along the way, so not just at the end of the 5 years, but really along the way, we look for opportunities for communication, translation and scaling. And similarly, that we have a working group that is really responsible for the principles and processes across the whole program for engagement and co-design. So I won't go through these in detail, but just to give you a sense of how that's structured. So the governance committee is Western Alliance and its members, because it sits within Western Alliance. and it's responsible for the kinds of things you might imagine a governance committee to be responsible for. But it's quite a useful structure because the health services and the PHN sit on Western Alliance. So it's a good way to continue to engage at a high level with the organisations with whom we need to continue to work. The executive team consists of a number of the chief investigators from the grant, and the reason I put this up is just to give you a sense of that diversity. So there are a number of universities. There's also, a number of people from health services and the director of our rural health organisation as well. Again, this won't be a surprise. It really is around project delivery. The advisory committee I did just want to touch on because that's obviously one of the areas where NARI comes in. So as I said, Sue sits on some of the working groups and the investigator team, but we're also engaging with NARI at this advisory level. And so the idea with this is and we haven't established the committee yet because we're still kind of reviewing who else we might need to have on the committee that we didn't think of when we put the grant in. But the idea is really to keep providing that external lens to the program. I mean, the whole point of this program is to try and develop capability and outcomes that are useful to the nation. So we want to work really hard to make sure we've got good people continually asking the right questions to make sure that we don't kind of develop a really internal gaze. In addition to that, we're hoping that this advisory group can support the development of scaling of some of the outcomes. And as I said, that might be capability building outcomes, as well as quite small or incremental improvements to home-based care, as well as maybe more major changes. And so at the moment, the advisory committee, sort of as stated in the grant, included a number of the smaller rural health services who didn't have the capacity to kind of commit to sort of the investigator level. And as I said before, NARI, Consumers Health Forum and AHHA. But we're sort of, this is a work in progress. So very interested if you have any other suggestions there. I've spoken about the working group, so I won't go through that again. So I guess just to finish off, we really are keen, as I hope I've indicated, that this program has some really substantial outcomes. So, in my mind, the two key ones are development of sustainable rapid research translation capacity across Southwest, regional and rural Victoria in a way that hopefully can develop learnings for scaling and implementation, and also improved health service provision of home-based care for rural and regional older Australians, again, in a locally relevant way that hopefully has opportunities for scaling more broadly. So I'm going to leave it there and just acknowledge all those who've been involved in the development of this and other large research programs, and really happy to hand over for questions.
Well, thank you very much, Anna. We do now have some time for Q&A. So if you have any questions, please submit them now through the chat function. Alternatively, if you'd like to ask your question in person, you could turn on your camera and microphone and we'll be able to call on you in turn. So I can see we've had quite a few questions come through from Mark. So I can start running through them. A general question to start off with, where does mental health and prevention fit into the process?
Yes, they're both good questions. So mental health fits in the sense of, to the extent that the hospitals offer home-based care in that area, it will definitely fit in. But having said that, there are not many home-based care initiatives that the health services currently offer that really meet mental health needs. So it's not out of scope, but what I imagine will happen is that becomes more one of the key outcomes that both consumers and health services say they would like to measure. So I think one of the goals of making home-based care better is definitely around quality of life. So not so much mental health outcomes, but quality of life and patient satisfaction. So I think there'll be a lot of measurement of those sort of outcomes. So that's kind of my guess, but we haven't done the consultation with all the hospitals yet. So it's not out of scope. In terms of prevention, so I guess in the scale of secondary and tertiary prevention, and maybe you can clarify if you really meant primary prevention. So in the sort of scope of secondary and tertiary prevention, that will be a strong focus. I mean, I think that is really the focus of improving home-based care, in addition to sort of improving kind of quality of life. It really is to make sure that people don't progress when it's potentially avoidable. So that's a strong focus, but we won't be focusing on primary prevention through this particular grant. So yeah, happy for you if you want to clarify if I haven't addressed some of it.
So yes, Mark, I see that you've turned your camera on. Would you like to ask one of your other questions in person, or are you happy for me to keep reading them out? You're muted, but I'm getting smiling and nodding. So are you happy for me to keep reading?
Yeah, sorry, I was on mute. Yeah, look, go ahead, because the other people have got questions too, I'm sure. Yeah.
Well, I think the next two are questions about other organisations that may be involved in it, such as COTA, OPAN, John Richards Centre for Rural Ageing Research. So it was a very long list of collaborators there.
Yeah, no, these are great. So that was, as I said, that's some of the feedback I was hoping to get today. So at the moment, none of these are specifically engaged. And so what I'm imagining is both through the advisory group, and NAR is involved with the advisory group, they might also say, well, we can be the conduit to some of these organisations, but these are some you really need to have around the table. So I think if you've got recommendations about some that actually would really be good to have around the table, that would be appreciated. I think the other way that some of them might become involved is on a more ad hoc basis. So I know that some of the conversations that I flagged at the beginning that we're having are, well, there is some care into, for example, residential aged care, which is not run by hospitals, but they have some involvement in it. So through some of those discussions, I think some of the other organisations might also come in because they're involved in, delivery. But no, none of these are specifically around the table at the moment. So very happy for you to kind of make suggestions about those that you think would be really good to engage early on.
Great, thanks, Anna. And I think the last question here from Mark is, what might be the impact of the new federal restructured home-based support program?
Yeah, I think that's also a really good question. And also the state government, they've refunded or expanded funding for the Better at Home program. What we've said at the moment, which is kind of, as I was touching on before, what we've said at the moment is we think the priority should be programs that health services are currently already engaged to run. So we really want this to be helpful for health services. We don't want to come in and say, oh, you need to do this instead. But through both these initiatives, the state and federal, we've said it would be really good to, in our initial conversations, to think about how can we use their direction, of which there's not so much yet, but how can we use, the goals of the federal and the state schemes to perhaps inform the improvements that we might collectively identify. So I don't think there'll be a big impact in terms of setting kind of our basic timelines and direction, but I do think it will inform the programs that we might choose to focus on, and also the solutions that we might choose to prioritise.
Great, thank you, Anna. Mark, did you have any follow-up from that?
Yeah, look, just a general question really is the linkages, Anna, between community services and health. Obviously, I'm from the Wellbeing Clinic for Older Adults at Swinburne, and we have a rural and remote project in mental health that we're doing at the moment, and our consultation is very much about the link between health and community programs, especially around prevention. And you can't separate that, because the isolation and the social needs for contact really are preventative in terms of a lot of people who are stuck at home or at risk even to going into care. So I think there really needs to be an understanding of the role. And one of the problems is that, well, hopefully the present government will change, but there's been a task-centred funding for community programs where only the function is supported and funded, and not, for instance, Meals on Wheels. A lot of people relied on Meals on Wheels coming in for a social contact and a chat, and also monitoring people's health and things. when it comes down to a task-oriented funding where they're just simply dropping off a meal and going because of the time pressures and everything, it takes away some of the fabric of communities that have relied on these sorts of services. And I think that's what worries a lot of people in our consultation, is that, you know, just concentrating only on health and the health services without bringing in the community supports, you know, and they're also the main source of information, because where do older people get their health information from? Because of lack of specialists and things, they get it from the corner store or from the person who also has diabetes or you know, who suffers from Parkinson's, and they consult them because there isn't the availability of specialists. So I think there needs to be a broader focus on the community as well. And I'm sure you get that message as you progress through the consultation process. I just want to make that point, Anna.
Yeah, no, it's completely well made. I completely agree with you. And I think you're right. Like, as I said, I think in one of the slides, you know, we had to start with one sort of scope that was contained. So there are two kind of specific thoughts in response to what you're saying. One is, so the approach that we have proposed in terms of trying to identify where solutions might be is kind of a systems mapping approach. And so we've just done something like that with acute mental health care in Barwon. And what those sort of systems approach identifies is exactly what you've just said, that actually the big issues have to be around, you know, integration with community care, housing, like this is in the acute mental health space. So I think that the process we're proposing, while it will start from the health, you know, the health service perspective, I agree with that. I think it will immediately illuminate exactly what you're saying, and that gives us an avenue to say, well, we need to look for kind of solutions there, which might be about better integration, better communication. The other thing, though, that you've made me think is, you know, maybe that's a core kind of representation that we should put on our advisory group, so that that voice that you're kind of bringing to the table is kind of always there. Because I think we've recognised it's critical, but we haven't kind of filled in all the gaps yet. So that might be quite useful. So thank you.
All right, thank you very much, Mark. I must say it's very exciting to hear about co-design research being conducted. I know a lot of people at NARI are very enthusiastic about co-design. I was wondering, in your initial kind of identifying priority stage, you're going to have a great deal of input from different people. Have you narrowed down at all what kind of co-design processes you want to use, and whether or not you're going to aim for an online or an in-person approach?
Yeah, no, that's a really good question. So in terms of you know, which larger programs are we going to focus on? So not so much what are the solutions, but which are the programs, that will be through fairly traditional kind of consultation, I think, across all the different health services. So really a listening kind of approach to start with, and see what commonalities emerge, and try and focus on programs where there might be common kind of prioritization. In terms of the solutions, so the approach that we're going to use, which we can't use in infinite number of cases because it is resource intensive, is going to be the kind of systems building, group model building approach that I was just touching on before. So we've used that really well in prevention. And it's a really good way of bringing lots of different stakeholder groups together to give their perspectives on what's working well in that particular system, what's not working so well in that particular system, and seeing how the different parts of the system join up. So this systems informed group model building is what we're proposing to run, and that is face-to-face primarily. But we have trialled it again in prevention with digital tools for either people who don't want to or can't come to sort of in-person sessions, or people who might want to add something after the fact. So we may well, I think that's yet to be informed by the different, you know, communities that we work with, but we may well do some digital systems informed group model building, but the primary will be face-to-face.
Great to hear. All right, well, if there are no more questions for Anna, just pausing to see if any more arrive. In that case, please join me in thanking her with your clap reactions.
Thank you.
All right, so everybody, next fortnight, Lee Fei Lo will be presenting post-diagnostic support and rehabilitation for people living with dementia. So please join us next fortnight on Tuesday, the 7th of June at midday. And thank you all very much for attending our Seminars in Aging program.